Doctors hate shoulders, and for good reason. Being the most mobile joint in our entire body, they're also considered to be the most complex. However, up to 2 in every 3 people are expected to experience shoulder pain at some point in their lives. They are very frequent sites of injury thanks to chronic overuse or acute trauma. This is especially true of individuals who are doing a lot of overhead work. Athletes like swimmers, racquetball players, or throwers, and career paths like mechanic, contractor, or personal support workers. It's not uncommon that a patient may receive a non-specific diagnosis, like impingement syndrome, rotator cuff tear, or shoulder tendinopathy. While each of these diagnoses sounds like something, they don't exactly indicate what structures are being affected. To further complicate the issue, many different shoulder diagnoses may all have pain in a very similar area. In this video, we'll be breaking down the different sources of shoulder pain or pinching that I have seen in my clinic, and differentiating between each of them in order to be able to treat them better. Quick disclaimer time, this video is not intended to communicate a formalized diagnosis. I understand that shoulder pain and pinching is incredibly frustrating to deal with, especially if it's affecting either your chosen sport or career path. I myself have had 2 shoulder injuries, for which both will be mentioned in this video, one on each shoulder. And you better believe that that made my life as a competitive swimmer pretty damn frustrating. If you believe that you may have one of the conditions mentioned in this video, consult with a licensed healthcare provider whom you trust. By all means, use the information that you learn in this video as a talking point with the healthcare provider, but rely on them for a physical examination and medical imaging when necessary in order to confirm the diagnosis. And then also, most importantly, a proper treatment plan to address it. Got all that? Awesome, let's begin. As always, we have to start with the anatomy to know exactly what we're talking about. The shoulder girdle complex is consistent of 2 bones, which include our scapula, which is our shoulder blade, and our clavicle, which is our collarbone. The main joint within our shoulder complex is the glenohumeral joint, which connects the scapula to our humerus or upper arm bone. It's considered a ball-in-socket joint, which lets it have a very large degree of movement. The other joint to be aware of is the acromioclavicular joint, which connects part of our scapula to our clavicle. This joint allows for only a little bit of movement and is designed by nature to be more sturdy. Also, fun fact, the scapula is the site of attachment for 17 different muscles, making it one of the most involved bones in our body. Now, the trick to a proper shoulder diagnosis is understanding the primary function and movements of the most commonly compromised shoulder muscles or structures. Knowing the individual roles of each of the structures lets you reason out which ones are being affected even when the pain is presenting in a very common location. Let's start with the general diagnosis of rotator cuff tear or tendinopathy. A tendinopathy is easy enough to understand. You have a tendon and it's inflamed. Most patients initially coming to the clinic knows what that is when I say it, but the understanding of what a rotator cuff is a little bit off. And that's because our rotator cuff is actually consistent of 4 different muscles. So the diagnosis of rotator cuff tear can actually mean 4 different things. Do you kind of understand now why that's not a good diagnosis to give someone? The 4 muscles that make up our rotator cuff include the supraspinatus, which sits on top of the scapula, the infraspinatus, which sits underneath the supraspinatus, the teres minor, which is frequently grouped with the infraspinatus as it performs a similar movement, and the subscapularis, which actually exists underneath the scapula between it and the rib cage. Now, the most common rotator cuff tear is actually a tear of the supraspinatus tendon. Once again, that's the muscle that sits on the top of the scapula. Coincidentally, this is also what happened to my left shoulder. In order to suspect that your supraspinatus may be the site of your rotator cuff tear, we need to actively engage that muscle through its primary function. The supraspinatus specifically helps to abduct our arm, which is to move it upwards like so. It helps for the first 15 to 20 degrees of movement of that. It's our initiator muscle. So if you find that the first third of moving your shoulder up like this is significantly more painful than the second and third, it might be your supraspinatus that's affected. There's also an orthopedic test known as empty can test, which I'll show now, that includes putting your thumb up, followed by your thumb down if there's pain on keeping your arm up for either of these movements. Again, another suspicion of your supraspinatus. Although this particular exam also tests for the impingement syndrome that we mentioned earlier, again, that's why it's important that you consult with a healthcare provider. Looking at the infraspinatus and the teres minor, these 2 muscles work to externally rotate the shoulder or to move it outwards. Following the same line of thinking as before, if we can challenge the shoulder in external rotation, and this is the thing that lights up your complaint, you might have an infraspinatus tear, or a teres minor tear. Again, those two muscles are oftentimes grouped together. And then lastly, for the rotator cuff muscles, the subscapularis does the opposite of the infraspinatus. It rotates our shoulder inward. The way to test this one is to place your hand behind your back and then try to lift your hand off of the back there. If that lights up your complaint, you might have a subscapularis tear. Now, I've mentioned a few times that when shoulder patients come into the clinic, they often cite that they have pain in a very similar location, despite all of them having different diagnoses. Typically, they point right here and say, "Doc, this is where it hurts, right in this spot." And while that is well intentioned, it doesn't actually provide very much information. To understand why not, we look at the anatomy of the front of the shoulder to see that we've got quite a bit going on here. Right away, we've got the supraspinatus insertion, we've got the subscapularis insertion, we have the acromiohumeral space, we have the acromioclavicular bursae, and we also have the biceps tendon. Any of these structures has the potential to be a pain generator. When a patient says it hurts here, it could be 5 different things. It could actually be 6, but we'll get into the 6th later. We've already talked about the subscapularis and the supraspinatus, so we'll move past those. But let's take a look at the diagnosis of impingement syndrome, as it's tossed around just as frequently as rotator cuff tear. When healthcare providers talk impingement syndrome, they're specifically referring to the acromiohumeral space. That's this little area right here. Now, true impingement syndrome means a decrease in the amount of space in this region. This can be due to either arthritic changes, meaning that the bone is enlarging and growing in ways that it shouldn't be, or soft tissue changes, which could include inflammation or swelling of the tendon or bursae nearby, which again, if those things increase in size, the space in the acromiohumeral space decreases. Basically, if the space decreases or the stuff inside swells or increases, you could get true impingement syndrome. Now, this is pretty easily identifiable through some medical imaging. You can either get an x-ray to rule out the arthritic changes, or you can get diagnostic ultrasound to rule out the swelling. It's also entirely possible that the biomechanics of your shoulder are off, which result in unusual amounts of narrowing through usual movements. This is considered secondary impingement, not primary. Once again, you can do the empty can test to suspect this, but the problem with so many of these structures being so small and so closely located is that it's hard to be specific in targeting each of them. As well, another common source of shoulder pain, especially in us top-heavy males, is a biceps tendinopathy. This isn't usually a patient's first line of thought, because when they think biceps, they think their arm. Why would a muscle in their arm be causing pain in their shoulder? Well, if you've been paying attention to the anatomy cutaways, you'll see that the biceps tendon actually extends right up through the shoulder and attaches to our scapula. Fortunately, testing a biceps tendon is pretty simple. You can do it by literally doing a biceps curl and feeling for that tendon. If that spot is particularly tender or painful, might be a biceps tendinopathy. Worth noting is that the biceps muscle is actually responsible, yes, for bending the elbow, but also for supinating the wrist or turning it upward. So if you're testing this yourself, don't do a hammer curl, do a full curl. The last diagnosis that we'll be talking about today involves a structure that hasn't been mentioned yet, but is very important to consider, as it's an oft misdiagnosed or missed idea. If you've been through multiple different practitioners with multiple diagnoses and you haven't been getting better with any of them, you might want to consider this one. Existing underneath all of the musculature and even within the joint capsule of the glenohumeral joint is this extra little lip of soft tissue. This little lip of soft tissue is referred to as the glenoid labrum. Glenoid means shallow bowl, it's referring to your scapula, and labrum literally translates to lip. The function of this labrum is to provide some rudimentary stability and support to the humeral head within our shoulder socket. Now, in cases of chronic overhead work or acute trauma, such as falling on an outstretched hand, which we refer to as a fouche injury, you may actually injure this lip of soft tissue. The resulting injury is something that we describe as a SLAP lesion, which is actually an acronym for superior labral anterior to posterior tear. Those are complicated words, but they're just used to describe the structure itself, as well as the most common site of injury of it, which includes right by the biceps tendon as shown here. That's also why orthopedic testing for the biceps tendon may actually also trigger if you have a SLAP lesion. Funnily enough, there is another orthopedic test known as the biceps load test 2, which tests for the slap lesion, yet it's named after the biceps, so. And there's also the pain provocation test, which is probably your best indicator for it. However, the downside to this diagnosis is that labral tears can only be definitively diagnosed by an MRI. That means that if you're in the States, you're probably gonna have to pay some money, and if you're in Canada, you're probably gonna have to wait a long time. And that's all for today, guys. Remember that the internet is not a good place to self-diagnose yourself, and again, not to step on my own toes, but that includes my YouTube videos. If you believe that you may have any of the conditions that we talked about in this video today, please bring your questions to a licensed healthcare provider and use this video as a talking point. It's on them to give you a full history and examination, and then conduct their own diagnosis and treatment plan. And most importantly, if for whatever reason you are unsatisfied with the diagnosis you are given by a practitioner, or feel like it's just not fitting properly, seek additional opinions. Seek additional educated opinions, actually. That's a very important distinction. As always, if you have a spare 3 seconds, please remember to like and subscribe. It'll help me to print in color. Why is printer ink more expensive than a whole new printer? You can click here for the previous video, or you can click here for the most recent one. Have yourselves great days. Done, pain provocation done, biceps load 2 is done with you laying.